This conference will now be recorded.
They make it sound so professional, this conference. See that? We're all in a conference here. Hot shit, right? Okay, here we go. Welcome to ANCAN's Active Surveillance Group. First and foremost, we'd like to thank the sponsors that make this possible, that help all the ANCAN and all the different groups that we support. Bayer, Novartis, Johnson & Johnson, Myriad, Telix, and Blue Earth Diagnostics. I'm just going to go right down the roll call and see who needs time. And we do have a new person aboard this evening, and we'll give him ample time to speak. The new people, there's only one this evening, won't be a problem. We'll extend 15 to 20 minutes to try to get a picture of where you are in your journey, to get input from the rest of us on the screen that you hear, and then see if the other people that need a little bit of time, they will tell us what's going on, and if you need more time, we'll come back to you, or we may have more than enough time. All right, Bill, do you need any time this evening?
Oh, I don't, thank you, Gary.
All righty. Ed in Virginia, do you need any time, sir?
No, thank you.
All righty. Alan in the Big Apple, need any time?
I could ask a quick question.
No problem. All right. Jeff, you need any time? You're on mute. There you go.
Shit. I got this thing figured out. I do not need any time this evening.
Okay.
This is a recording. Okay.
Too late now. It's forever on the internet now.
It's a recording of a recording. Okay.
Dan, do you need any time?
No, I'm good.
All righty. Rick in Atlanta, do you need any time?
No, sir, I'm good, thanks.
All righty. Dan in Idaho, good to see you, bud. You need any time?
No, I'm fine. Thank you, Gary.
All righty. Steve, as I said, we'll get back to you. You will be the first to go. Alan in Vermont, you need any time?
I'm all set, thanks.
Okay. Derek?
Yes.
All righty. We'll get back. Bill in Virginia, do you need any time?
No, thank you.
Okay. Donald, do you need any time?
No,
You were just going to listen? Okay.
Yeah.
Ignacio, do you need any time?
No, thank you.
All righty. Well, I see Michael Thompson's aboard. Do you need any time, Michael?
No, I think I'm okay. Thanks, Gary.
Okay. Welcome. All right. I think that's everybody. I forgot to Eric. Do you need any time?
No, thanks.
Okay. All right. I think I've got everybody, correct?
I think so.
Yeah, I think
Somebody
I have
just came
everybody.
in. Greg Burns is in the house.
Who else just joined us?
Mr. Greg Burns.
Oh, excellent. Greg, do you need any time, and where are you?
Same as usual, and I'm good. I'm good for today. I just wanted to listen. Thank you.
Okay. Things well in Singapore?
It's the same. It's a quiet day in Lake Wobegon.
There you go. It's a tough life, but somebody's got to do it. I'm telling you. All right. Well, I tell you what, Steve Anderson, I'll introduce you to real quick to Eric, who's one of the moderators, and he's going to go down our little questionnaire, and then we will open it up to the other members and find out when the journey started, where you're at, and what we can do for you. Go ahead, Eric.
Sure. So how'd you hear about us at ANCAN?
Well, I went to another group last week, and one of the people in the group told me about this group.
Was it an active surveillance group, or was it?
No, it was another group that's it's virtual, but it's I think it's called the Brotherhood. I can't remember the name, but yeah.
Okay, yep.
Yeah.
The Brotherhood.
Okay.
We got it.
Excellent. How did you, and where are you located?
I live in Tampa, Florida area.
Another Floridian.
Yep. I'm in Melbourne. I'm in Melbourne, and Dan's in Pensacola.
Okay.
Would you like to share your email with either either Gary or myself? if you would like to subscribe to the newsletter for reminders of the meetings.
I think I'm already on that. I subscribed already.
Okay.
But I can add it to the chat if that makes sense.
Yeah, you can either do it to everyone or you can select it to specifically to me or Gary.
Yeah, you can send it. Why don't you send it to Eric and he can send it on to Kiernan, who is our, she is one of the paid members of the ANCAN staff that keeps tracks of attendees, new people, and also make sure that everybody gets the pertinent information that's sent out.
Okay, once I've finished talking, I'll make sure I'll do that.
Perfect, thank you.
How old are you?
I'm 61.
Okay. And might you be a veteran?
No, I'm not.
Okay. And when were you first diagnosed with prostate cancer?
Well, I guess I mixed you earlier than you guys. I've just had an MRI, and that I'm probably going for a biopsy. So I'm actually potentially premature, but I want some advice even at this level.
So you're not fully confirmed, but you're getting all the tests done appropriately.
Right. I have a high PSA. Yeah.
Is it a high PSA that
Yeah.
Okay. All right. Something had to make you think about an MRI, or your physician about an MRI.
Sure.
Okay.
I can give you.
What was your first PSA test result?
I'll give you a little more background. So my PSA was in the low threes for a while. I guess it was in like 2020, it was in high 2.7. 2022 was 3.59, then 23, 3.81. And then my primary care physician referred me to a urologist at that point. And in mid 2024 went up to 5. Early this year went up to 5.14. A month later, he wanted to check it again. It was 5.19, and then he checked it again in April. It was 7.62, and he said that he wanted to immediately schedule a biopsy. That was in April, and so he wanted to do but he didn't seem real confident that he would success. He said, he was going to do a random biopsy, and in doing research, it seemed like my urologist may have been old school. Yeah, I think he's a great guy. I mean, but he may have been old school, and I looked like I should do an MRI, and so I went and talked to him about that, and he sort of refused to give me a prescription for an MRI. He said, well, you're gonna have to do the biopsy anyway. That's not going to do anything. Those don't really work. And I said, well, I don't know if I agree with that. So I went back to my primary care doctor, told him what had happened, and he gave me a prescription to an MRI. And I did that several weeks ago. And while I was at my primary care physician, he said, why don't we do another PSA test? And we'll also do the ISO PSA and the total PSAs while we're here. Mm-hmm. And that came back with a free PSA of 9.5. But in drawing the blood, he had issues with that. So he wasn't able to get he's not a urologist. So I guess they didn't draw correctly for the ISO PSA test. So he said, come back again, like 10 days later. And we got all those other scores, but then the PSA was down to 6.8, which is still high. But by that point, he'd already given me a prescription for an MRI. And so I went to got an MRI, and I got the MRI results back. And so, I mean, if you have a set of questions, I can answer that, or if I can read through whatever's makes most efficient.
Let me ask about the MRI. Was it a 3T MRI?
It was a 3T multi-parametric MRI.
Excellent. Good. Okay. Did you have contrast or not?
Let me go back a little bit.
Sure.
Real quick. Stephen, on these PSA tests, has anybody told you what to do or not to do? And are they getting done at the same lab? All those numbers you gave us, were they done at like a Quest lab, or were they done at
They were all at Quest.
Okay, all right. So the same lab, because each lab has a different what they call assay. So if
you
went to someone, they could be using a Hoffman-LaRoche or a Beckman-Coulter, and you can get different numbers. VA will give you a different number. Did anybody prepare you for the PSA test? What to do, what not to do?
I I actually went online and made sure I didn't go bicycling. Didn't, there was certain things that they said not to do. And I think my doctor may have given me some advice on that as well. So,
Well, that's good because sometimes people go in blind and they've had some type of sexual relationship within 72 hours or ejaculation, tear down a wall with their brother-in-law the day before, ride a bike for 50 miles, 3 days out. So it's good that you did the research because sometimes that will cause the number to skew. And also, no one to date has been able to explain the rise and the fall of PSA. Sometimes it seems that there's no definitive answer. You could have a small inflammation called prostatitis that you don't even know about. That's totally not symptomatic. That can cause the numbers to go up. I myself had a 6 go to a 12, double, and then go back in the 6s and the 7s. Other people have had the same type of thing happen. Of course, it depends upon your age, the size of your prostate gland, so on and so forth. But go ahead, Eric. Let's find out what the MRI had in store.
Yeah, also, just out of curiosity, Steve, was the doctor that gave you the advice about the PSA, was that your urologist or your primary care?
I think the urologist gave me that, and then I went online as soon as it started. I guess in January when it was it was in the 5s, and my urologist was a little concerned. I started doing some research to try to sort of learn a little bit more.
Okay. So you got the 3T MRI. Did you have contrast or no contrast?
With contrast.
Okay. And any lesions found?
Yes, there was one lesion of 1 centimeter. It was in the mid-gland posterior transition zone.
How big was it?
1 centimeter? 1 centimeter.
Okay. And did they give you a score of that lesion of a PIRAD?
The PIRAD score of 3.
3. That's good. It seems to be on the lower side of things. And what was, have you had the report read by your urologist yet, or just your primary care?
Well, that's the thing, is that my primary care is not, I got the report directly. I went to Simon Med, got directly from them. And so that's where I am right now. I've contacted Moffitt about getting a, Moffitt here in Tampa Bay, about getting a, biopsy done, but I want to make sure that I'm doing that, find the right person, doing the right thing, and then do I need somebody else to check the MRI to make sure that's where I am right now. Sort of before I have anybody stick needles in me, I just want to understand: do I need to get more information to Moffitt, and who within Moffitt should I have do the biopsy, or is that not as critical as some other surgeries that you do?
Well, let me ask you this. Do you feel like at this point your current urologist is out of the picture?
Oh, he's out. I need to find somebody else. Yeah.
Yeah, good plan. So anybody in Florida recommend any urologists near, what'd you say, Tampa?
I live in the Tampa Bay.
Well, Moffitt is the center of excellence. Moffitt's where you want to go. Now, I don't have a name, but I'm sure we're going to be joined later by Rick Davis, most probably, who is the founder of the whole group, the whole ANCAN. He most probably can have a name. If not, he'll get you a name for sure. Right. And of course, you want a transperineal biopsy. You don't want a transrectal. I don't think Moffitt even does transrectal, although that is a heated topic in the the Urological Association that takes care of the whole United States about transrectal versus transperineal. Of course, the question is the chance of getting sepsis going through your rectum and the fact that you would have to be prescribed antibiotics.
Right. They do. In talking to Moffitt, they would be transperineal.
That's the way you want to go.
But I want to make sure. I don't know who's going to be assigned there to do it. I just didn't know if they maybe have 10 doctors. There may be one better than another. I'm just trying to. That's sort of where I am, trying to make sure I make the right decision.
Well, first of all, going to a center of excellence is certainly the first step. And everybody, I mean, they are the cancer specialist in the Southeast for sure. At this point, them in Mayo. I go the other way to Jacksonville to the Mayo Clinic.
Okay, gotcha.
And Dan up in Pensacola, we turned him on to the people he was seeing. We turned them off, and he went to Mayo, and he's pleased. He's got the head of the department dealing with him now, so you can see him smiling up there. He's liking what I'm saying.
My story is pretty much the same as your story. I had to divorce myself from my urologist. He didn't want to do an MRI either.
Okay.
And totally ridiculous. As far as once they do the MRI, we have people that can second read it, which we certainly believe in second, third, sometimes fourth opinions on everything associated with this disease. Because once you get a biopsy and the pathologists look at it, they're the ones that determine you've got this, that, or the other thing, the volumes thereof, and any other things that can be associated with it. So we always suggest after the initial biopsy to get it reread by either Jonathan Epstein, who's out of Long Island, or Dr. Ming Zhao, who's in New York City. They're the two people we like for a second opinion. And most probably, when you get the biopsy, shortly in the world of prostate cancer, shortly is 1 year. They would most likely maybe look for a confirmatory biopsy, but that's way down the road. So that just kind of laying the groundwork of what normally happens. Your case could be different, as is other people on the screen, but that's like, if you're looking to what might be ahead, that's a pretty good picture.
And I just posted the links in the chat for second opinion on biopsies.
Okay, so let me see if I can find that. Oh, okay,
Yeah.
gotcha. Here's the chat.
If you were curious about the MRI,
I can post that too.
Yeah, we've got a second opinion for the MRI. It depends. That again, you have to be your best advocate. And what we try to do here is, people that are on active surveillance, they do have to be active, and they have to pay attention to what's going on. And we try to keep everybody abreast of what's available, where it's available, and of course, what we think about something they might say to you, or they might want to, a procedure they might want to perform, or something you may not be totally aware of or informed about.
Okay.
Do you have any?
I'm sorry.
No, go ahead.
And regarding the second opinion on the MRI, you just call these people or email them and say, hey, I've got my disc, or I think that Simon Med can send them the images directly, and just hire them, and then just sort of say, I want you to get a second opinion. Is that what you do, or how do you do that?
Yeah, some facilities allow you to download the files. They're called DICOM files.
Yeah.
And otherwise, you got to go and get a physical CD, and then you'll have the files. But either way, those could be shared digitally for a second opinion.
Yeah, I have the CD, and it's on my computer, so I can send somebody a link if they have the facility. So,
Sure.
I'm sorry, go ahead.
So you go ahead.
Marlon, sometimes my dog, excuse it. Sometimes, like for instance, my guy in the Mayo, he wants the MRI done there. I don't know if Moffitt might say to you that they want to do another MRI before they do the biopsy. They might say that because of just because they want to do it on their machine, and perhaps they're going to fuse the MRI while they're doing the biopsy, so that they know where to go from what they're seeing from the MRI. And like I say, he up in Jackson, I asked him, can I get the MRI here? And he said, no, I want you to come up and do it here. And that could just be throwing the business to the Mayo Clinic. Steve, I don't know. That could just be him saying, no, come to my place, because we're going to make the 20, X amount of money. X amount of money.
How long ago
but
was
you
it?
can ask. You can definitely ask.
How long ago was your MRI?
It was done May last month.
May, okay, so it's pretty fresh.
A couple weeks old, yeah.
Yeah. So hopefully the quality is good enough they can reuse it, but again, it's up to the doctors.
Okay.
Have you had any family history of prostate cancer?
No. Not that I, well, I gotta say, not that I know of.
Right.
My dad's still alive. He's in his late 80s. He's got memory care, so I really can't even ask him. He doesn't have any, you know, any recollection of any sort of health. He's actually a physician, but he has no. And my mom, she's sort of there with him, so she can't. She has no memory of this either. And then my grandfathers died early. One died of heart disease, the other died of stroke, and so I just don't know.
Sure.
So genetic testing may be an option to figure that out, I assume.
All right.
Yeah, absolutely.
And
Genetic test.
yeah, that's what my next question is, if you had any genetic tests for BRCA genes or anything like that.
No, how would I go about doing that?
That could be done either through your urologist or even your primary care physician.
Okay.
They can
Now,
order that up for you.
I believe the PROMIS study is still available as of the
Oh
announcement.
yeah.
As
But
of
I
the
haven't been
announcement.
diagnosed yet, so I don't think because I looked at that, I don't think I can get
True.
into it yet.
I'll still throw it up in the chat just so you have
Okay,
it.
great.
It might still be open after you get, after you get diagnosed, after they look at the
Sure.
lesion with through the MRI and the biopsy. I see the boss has joined us. Rick, I got a quick question.
Yes,
Stephen
sir.
Anderson joined us for the first time this evening. He's in Tampa,
Yes.
Florida,
Yep.
and just brand new MRI last month. Do we have a doc that we like at Moffitt?
I need to look again, with the urologists. Howard's really better on the urologist than I am. But let me look through. Eric, if you're going to put the promise in the chat,
Yeah.
are you using our? Yes, you are. Good man.
Yes, I was
Thank
a
you.
good boy.
Thank you. Just so that you guys know, a couple of years ago, we did a webinar with Promise, and they gave us a unique link so they could track how many people we sent them. And so that's why we use that one. And I think we're well over 200. I don't know how many exactly.
Excellent.
Okay. So yes, Stephen, since your family history is kind of clouded, that's an unfortunate circumstance for both your parents. Truly sorry about that.
That was my grandfather's. So I mean, yeah, but my parents. Well, I guess for my parents, they've memory care, but they're in their late 80s, early 90s. So that's good. So
Do you have access to their medical history?
I'm sorry.
Do you have access to any of their medical history as a?
Not real. I mean, I can follow up with my sister and see if she may, but I since this is sort of new to me, I need to figure that out. But yeah.
How are you feeling in general, anxiety or anything like that?
I got really nervous when my PSA went to 9.5, but when it went back down to 6.8, it made me feel a little better. But when it went from 5 in March to 7.5 in April and then 9.5 in May, that gave me some pretty good anxiety.
Well, we do have another meeting on Thursday nights, same room, same time, called Men Speaking Freely. So you can talk about anything you want except treatment.
Done.
So definitely lean on that if you feel like you want something to chat about.
Yeah. Jeff, you got a question for Stephen?
Here we go. Hey, Stephen, how are you doing?
Right.
Hey, just maybe let you know something, and maybe you already know it. I know your initial urologist didn't want to give you the MRI, and he said he was just going to go in there and do a random biopsy. Even if you get the MRI and they should choose to target any lesions they see on it, I guess you might want to be prepared for the fact that they're still going to want to, in addition to that, do a random MRI, a random biopsy. Yeah. And I don't know if you knew that.
Yeah, I think they'll still probably use 12 needles or whatever it is. Do they?
Okay.
But
yeah, typically, oh, go ahead.
but yeah, but at least they'd have better shots at what they're doing.
Yeah, typically they would maybe take, if you had one lesion, they might take 2 or 3 cores out of the lesion and then just do a additional 12 core random biopsy on top of that or in addition to that. So I don't know if you were aware of that or not. So I just thought I'd bring that up.
I appreciate that.
Thanks, Jeff.
Yeah, thanks, Jeff. Yeah, the Men Speaking Freely is a highly recommended group. And the other thing, especially in your case, time is on your side. You've just started on the journey, and I have a little thing where I say it's no need to get nervous and jerky at this point at all. You're gathering information, doing all the right things. Sounds like you're pretty in depth with research, which is good. The more educated you are, the more questions you can ask, and the better you can feel, which helps you deal with the anxiety part of it. Ignacio, you want to say something to Stephen? I mean, excuse me, Derek. I'm sorry.
Oh yeah, I just wanted to clarify that it's not 12 needles; it's 12 samples.
I'm sorry. Okay.
Individual needle each shot. And if they're doing transperineal, I don't know. Did they knock you out for that, Gary?
Yes, they do. Yeah,
Other than the doctor,
they
really.
knock you out, and that's basically the way to go. And it's a hospital setting, and the anesthesiologist comes to talk to you. There's people on the screen that have a transperineal that had very little discomfort and bleeding afterwards, and there's some people that had mild discomfort and bleeding for a longer period of time. I didn't have any discomfort and minimal bleeding. It was no big deal. Everybody is different, but it certainly is the way to go in light of a transrectal and the chance of sepsis and having to take antibiotics. The mainstream are trying to keep people away from antibiotics because there's nothing new in the pipelines. It seems the last webinar I listened to with the doctor from South Florida, down in Miami, there's nothing in the pipelines. They only have what they have now, and they don't want to abuse. They don't want anybody, even on an individual basis, to use them if they don't have to. I mean, I don't like to take anything I don't have to. Most probably everybody in general doesn't like that. So it alleviates the need for antibiotics and the chance of sepsis, which is very low. But as I've said a million times, I don't want to be that one guy. I don't care if it's one guy in 500,000. I don't want to be that guy. So that's, when you can eliminate that altogether, to me, that's a good deal. Bill in Virginia, you got something for Stephen? Bill?
Go, Bill.
Sorry about that. I caught whatever Jeff had. I was just wondering if anyone had any information about the risk balance of complications from general versus going under for that procedure, as opposed to the transrectal procedure where you're awake.
I believe they use propofol, don't they?
Yeah, I think it's a twilight, not a full.
It's a twilight. Yeah, you just don't remember anything. It's the best nap ever, as far as I'm concerned. It was a really good nap.
It's similar to a colonoscopy.
I would save that question, Bill, and ask it in the low intermediate, because I'm sure Dr. Mark Perlow is quite an expert on that, because a lot of his patients would have had the choice of a general anesthetic or a twilight, and I'm fairly sure he'll be able to give you a solid medical answer.
Yeah, I'm of the opinion of if they're targeting a 1 centimeter lesion, I don't want to be jolting around when the gun goes off. But that's just me. Just put me out so I'm not moving, I'm not twitching.
And I think the procedure is as far as a time frame goes, is so minimal to take those 12 cores and to target the lesion. The twilight thing works fine. It's not as if they're going in there and reconstructing your colon or something, where they don't know how long they're going to be in. They're
Right.
pretty. I mean, there's always an exception to the rule. God forbid something could go awry, and they would just put you out a little bit deeper. But I do think it's that twilight kind of thing. I've had colonoscopies and biopsies, and basically had the same reaction to both.
There's
Jeff,
a,
you had
I
something
guess
for Stephen?
there's maybe I can add a couple things before we. I have BPH and my and I guess in my MRI it says I got a 74 cc prostate, so it's a pretty good sized prostate. And I'm taking doxas something or other. I don't have the. I can probably get it in a minute, but I'm taking medication for that.
When did you start that?
A couple years ago.
Oh, okay.
Is the medicine on a daily basis?
Yes,
It's
take it
not
every night.
Flomax. It's not Flomax.
It's
That's not
Dox. I'll look it up.
Doxycycline or something?
Doxycycline, something like that.
Does that affect your PSA level?
I don't know. It's prescribed by my urologist, but that's a good point. I don't know the answer to that.
Some of them I know do, and you have to divide your PSA score in half to get a true reading.
Yeah, it's not that one.
Okay.
No.
Thank you, Rick.
Jeff, while he's looking that up, you got something to ask him?
I think that's what it is. I mean, so I can.
Damn this thing. I think Derek is ahead of me with the hands.
Oh, okay.
It's fine. What I was to say about anesthesiologists is bear in mind that they're typically not covered by insurance unless prescribed by the doctor as needed. So you may want to discuss that with the urologist up front and your insurance company as well.
Okay.
Yeah.
Thanks.
Yeah. For people.
Well, I was just going to say, when it sounds like everyone's saying if it's transrectal, they always knock you out, and if it's and transperineal, the transperineal, they always knock you out. And that's not the case, because I've had my initial transperineal at Hopkins, I was awake. And then the second time around, they tried it again while I was awake with local anesthesia, and I couldn't handle it at that point in time. So I had to get it done then under that, what they call MAC anesthesia, which is what you're talking about in reference to a colonoscopy. But I'm not sure based off my experience, I'm not sure all facilities will give you twilight anesthesia for a transperineal.
It definitely depends on
I believe
biopsy.
you're correct. I believe you're correct, Jeff. That they didn't offer it to me at Mayo, and I would have. I don't know whether they didn't because they bigger money and easier to do with me knocked out. That could have been the reason why I wasn't knowledgeable enough at that point, like I am now, to say, hey, look, I can handle it. I'm a big boy. Just local anesthetic, and we can get this done. I believe you're absolutely correct. It's not. It's not
Standard is what I'm trying to say. It's not standard for them to put you under twilight. If you want that, you'll have to ask for it up front.
It definitely varies by the doctor for sure.
Yeah.
And Derek brings up a good point. If you're, based on your insurance, of course, you're 61, you're not covered by Medicare, which takes a lot of the worry out of being close with this stuff. At 61, you have to get most probably approval for these things, and that might have a bearing on what they want to do or what they will do.
Okay.
So those are questions that you can take with you now and to ask, and that's part of what we try to do, is to make you the best advocate and make you as knowledgeable as possible, and to come up with the questions to the physicians so you can feel comfortable about what you're doing.
I had one more thing.
Oh, yeah. Go ahead, Jeff.
Real quick to Stephen. I think you said your most recent PSA was 6.8.
Correct.
And then you just mentioned a few moments ago, I guess based off your MRI, that your prostate size was 74 cc's.
Yeah, I know that there's a ratio between those two.
Okay, you got all that.
It's not as bad as if I had a much smaller prostate.
As it looks, right? You're at 0.09. That ratio you're talking about, and if you're below 0.15, that's a good thing. So
prostate health index.
Yeah, PSA. Yeah, your prostate, your PSA density. Yeah.
Yeah, and
Okay.
if I didn't have a lesion, they detected, I probably wouldn't even be considering
Right.
an MR, biopsy. But
Okay. Thanks.
One
Yeah,
thing
we
you can
appreciate
consider is,
we appreciate you being the engineer on duty. That was good. Thank you.
yeah, you could consider a urine test too before your biopsy because that'll detect aggressive cancers. Like I think it's called My Prostate Score. That's an option.
tell me about that, so I can go get a urine test, and that's a pretty good indication.
It's a like a biomarker in your urine that you can discuss with your urologist on whether that's something you can consider before a biopsy, if you even need a biopsy.
That would be
Okay.
something, especially in Moffitt. Your urologist, forget about him because he doesn't even want you to get an MRI. So
Yeah.
that guy in the
Right.
back. But that's something you could bring up with the doctors at Moffitt, a biomarker, a urine biomarker.
Urine
Let
biomarker. Okay.
Yeah, and let them explain to you what they think the value is if it applies to your case. After they give you that information, you'll have more information to research yourself and come up with an answer. All of these things are just little parts of the puzzle. The PSA, there's not one definitive something we can tell you to tell you that you have an aggressive or a less aggressive a cancer. It's all the steps that you have to take, all the tools that are out there, all the diagnostics that are out there, and use them to come up with the best plan for you.
Okay.
Dan, did you want to say something to Stephen?
Yeah, my comment is just on whether you have a biopsy with anesthesia or not. My first biopsy was 7 years ago, and it was transrectal, and there was I was awake for that procedure. There was minimal discomfort, and then 2 years ago, after 5.5 years, I needed a second biopsy, but at that point, I wanted to be transperineal, and I actually wanted to be awake during the process. And as it happened, my doctor did it in his clinic, and he didn't offer complete anesthesia, which is what I wanted. And I found the whole thing to be, very manageable, having it done without being put to sleep.
Okay.
Good to hear. Rick.
So I'm working on trying to get your name. I mean, one name I do recognize is the department chief, whose name is Pao Sang, Dr. Pao Sang. I don't know where he stands on active surveillance. I just know of him. I know people who have seen him. I put his information in the chat window, so you can. That's the other. It just so happens that Bill Franklin texted me during the call, but he's out to dinner with the family. But I asked him who he would recommend because he did have surgery at Moffitt. And I don't know, but we'll find out. And do we have your email address? We do. So you'll be in the we'll find you, and if I find it during the week, I'll send it to you. The other thing I wanted to say. Go ahead.
Go ahead. I'm sorry.
The other thing I wanted to tell the group is right on topic, right on point for what we're talking about right now. It's a really cute story. I had to go to see the PCP on Tuesday. I think it was Tuesday. I can't even remember. Monday. Because I have this. I came off my bike about 3 weeks ago and cut myself. It was a nasty cut, healed well, but I've got this ball of fluid on my elbow, which isn't going down as quickly as it should. And my doc wasn't there. So I see this doc. He looks really young. And he says to me, he's going through all my meds and everything. And he says, "Are you still on the junior aspirin?" I said, "No." I said, I took that after my cancer diagnosis. But then I stopped because a lot of people said it really didn't make a difference. And he said, "Well, what was your cancer?" So I told him I had stage 3 prostate cancer. And he goes on talking. And then about 2 minutes later, he says, well, I have to share something with you. I said, what's that? He said, I was diagnosed with 3+3 at age 36.
Oof.
I said, oh my gosh. So I said, how old are you now? He said, 43. He didn't look 43. I said, 43. I said, wow. I said, and is it all stable? He said, yes, but I'm coming up for another biopsy. I said, well, you really need to get a transperineal. Was the first one transperineal? No, it was transrectal. So I said, well, we'd really say transperineal. He said, well, I had a terrible time with my biopsy. He said, the first one was really, really painful. He said, the second one, I had to get a general anesthetic for a transrectal. So I thought, oh my gosh, we haven't heard that. We haven't heard that one before. I didn't say that to him. And then he asked me about, well, why the transperineal? So I said, well, there's a couple of really good reasons. It's first of all, it's much healthier, less chance of infection, and secondly, they can see things with the transperineal that they can't see. The anterior of the prostate is much more evident. Oh, so and then I said to him, "How's your diet?" Oh, he says, "Not so good." I said, "You like that carne seca, don't you?" He said, "Yes." And then I said, "How about exercise?" "Oh, I don't have time for that." He says, "Wait a minute." He says, "This is what I'm supposed to be saying to you, not you to me."
Who's the urologist or the doctor?
That's right. It was very cute. And then when I came home, I sent him that. I forget the name of the study, that recent study that compares the transperineal to the transrectal that came out just recently. Stephen, I'll put that study in the chat window for you too. It's a very good study, and it shows.
So where is he? Is he not here tonight in the room?
Why is he not here tonight?
I told him. He says, "Oh, I got a long drive home." I said,
"He's busy."
He said, "Dr. Carlos, you should be there." Anyway, I just thought you guys would appreciate that story, especially when he started talking about anesthetics for biopsies.
Yeah.
Well, once I select, so like if I go to Moffitt and they sign me somebody to do the biopsy, is that going to be my doctor, or can I change, or is it important that you get the right one from the get-go?
Well, I think what's important, the answer to the first part of your question is yes. It's usually very, very difficult to change within a department. So whoever they assign you. So I think what you need to do when you go to Moffitt and you ask them is you've got to find out which of their doctors is most interested in active surveillance. Because what you want is a doctor who is interested, maybe doing research. That's what I was looking through all the doctors to see if I could see if any of them named active surveillance. I didn't. But you want a doc who is committed to active surveillance.
And how do you find that person? Because you ask them,
Yeah, you ask them when you make the appointment, and you say, and if they say, well, we don't know, you say, well, can I talk to a nurse practitioner, or I need to talk to somebody, because there will be people in an NCCN center. There is going to be some people doing it, but there are some NCCN centers that aren't even that friendly to active surveillance, like Northwestern, for example. It's hard to do.
They don't make as much money that way.
That's not true in the centers of excellence, because they get paid the same whether they cut, they don't cut, they radiate, they don't radiate. I mean, the centers of excellence are different to the community. The community doctors, yes, you could say yes, that might be true, but I don't think that's true at a center of excellence. Who here has been to both a community and a center of excellence? Alan, have you been to both types, and do you find there's a difference in the attitude between the community doctors and the centers of excellence?
Yes. Well, if you mean me, I'm going to say yes, because my urologist who did everything right up through the diagnosis wanted me to get a PET scan right away. I put it on hold, went to Center of Excellence. When I saw Dr. Easton at MSK, he verbally laughed when I said my urologist told me to have it. He said, there's absolutely no reason you shouldn't be having it at this point. So even though everything else my urologist was doing was right, he was kind of pushing me through the process at an accelerated speed. So that's why I'm at MSK now.
Yeah, and the other Alan, you wanted to say something on that.
Yeah, well, I did find a significant difference between my initial urologist, although he was very nice, and he was supportive of active surveillance, but he made a couple of mistakes in talking to me and gave me wrong information. And then I went to my current doctor, who's had Dana-Farber, and he's just great. And he's very active in support of active surveillance.
So, Stephen, do you have any final questions for us before we move on?
Well,
Derek had something he wanted to say.
Oh, sorry.
And Stephen, you can take.
Yes, I just wanted to mention that I found in selecting a doctor, online reviews very helpful as well.
Okay.
Either Yelp or other.
Yeah, you could even try a telehealth visit if they offer that as a quick little interview before you.
I had a telehealth visit at Moffitt. It was before my MRI was read. It was after I had the high PSA numbers, and that's when they said. Then the next thing they said, well, you need to schedule a biopsy, and they said it's good to have the MRI before you get that done. So that, I mean, it was the timing was such that I thought I'd have my virus results by the time that was scheduled, but it didn't happen. So I guess.
And was that with a urologist or was that with a nurse practitioner or a physician's assistant?
It was with an physician's assistant, I guess a nurse practitioner, I guess is what it was.
Okay.
It wasn't with a doctor.
Okay.
It wasn't with an MD.
Okay.
So I guess the next thing is that they want me to schedule a biopsy, and I guess I'll call in. And should I ask who does the most biopsies, or is that as critical, or whatever doctor I get that does my biopsy, is that going to be my doctor?
Well, it is going to be a doctor, yes, but that's
Correct.
not what you want to be concerned about. You want to be concerned about whether they favor active surveillance or not. So
I want to ask
down the road, because that's what's really important. You don't want to get assigned to a doctor who's a cutter.
Okay, so I want to say who's more inclined to do active surveillance, and I'll call them and ask, because I'm going to have to call the scheduling office. I don't know how I'm going to be able to get. It's very, regimented how they do it. You have to talk to somebody, and then they schedule appointments, and so the only person I can really talk to is a scheduler.
It's the scheduler, but you say to the scheduler, look, I want to come in, I want to be a patient of Moffitt, but I'm really interested in following an active surveillance protocol because I'm a good candidate. I want to be sure you assign me to somebody who has an interest in active surveillance. And if they'll say, well, we don't know that. And then you say, well, I need to talk to somebody who can advise me who that is. And if they shut you down again, come back and we'll see what we can do. And, but you have to advocate for yourself. Don't let them push you around.
I got you. Yeah, that's what I'm trying to make sure before I do anything that I try to make the, and then I guess they'll probably read the MRI again before they do it, or they may want to do another MRI. So I guess, do I try to send my MRI out to somebody else before this, or just schedule it?
I would wait to see if they're going to make you do if they're going
another
to
one.
That you do another one.
Or just
And
offer,
as Rick said about the
to them that you just had one.
As Rick said about the scheduler, I understand, because if I was the scheduler, I'm not even going to know the doctors. Yeah, really. When you think about it, they most probably don't even know the doctors. They just have a rotating schedule, most probably, that they assign. So you might might have to make a couple of phone calls and say, well, look, I would appreciate if someone could call me back that has a firsthand knowledge of these doctors, because I want someone that is familiar with the AS protocol, which I intend to follow. Give them, open that door for them and let them get back to you.
Yeah, here's another thought for you, Stephen. Ask to speak to the nurse practitioner or physician's assistant that you spoke to on the phone the first time.
Sure. And what are those people specifically assigned to certain doctors? Would this be a nurse
Yeah,
practitioner's?
yeah, they are, and that's what was going through my mind. Whether that means they've already assigned you to a certain doctor if you come back, but you haven't seen him, so you've got a lot more leeway in switching doctors if you've only seen a nurse practitioner or a physician's assistant than if you've seen the doctor.
Gotcha.
But, if they can't help you at the scheduling, send a note. You're in their portal. Send a note to the physician's assistant and say, look, I really want to explore active surveillance. I want a doctor who's committed to active surveillance. Who do you recommend?
Okay, gotcha.
Another thing
That's very helpful because I haven't scheduled an MRI, so it's not like I'm canceling with anybody yet. So, okay.
Stephen, another thing I just thought of is if there's any local cancer support groups for prostate that might have some insight on who's appropriate at that particular facility.
The ones that are around here are doctors' offices. So I'm not sure that's going to be like urologists' offices.
Right.
I'm not. There's probably a bias towards those.
Sure.
I do get a reminder from a group around the Sarasota area that offer free PSA testing. In fact, this Saturday they've got somebody that's in a barbershop that's going to cut hair, and they're going to be free PSA tests. You might want to look.
There's a hospital which, I mean, if you could send that to me, that'd be great. There's a hospital that's in Sarasota that's got a regular in-person group, I think, and that's about an hour away. But I'll do it. I would do that if that would make sense.
I just found one at Moffitt. It's General Cancer Support Group, but hey.
Oh, great.
Got nothing to lose, and I just sent it to you in the chat.
Okay, that's wonderful. Thank you very much.
Next one is on the 17th of June.
Yeah, I mean, if you go to Zero and on their patient support page, you can look for a prostate cancer group in the Tampa area.
Yeah.
Okay.
Now, one thing I will tell you is that the quality of the moderation is very patchy. Sometimes it's great, sometimes it's not so good. They don't have the supervision of the moderators the way that ANCAN does. So the information you may get, and there are moderators there who discourage active surveillance. So you can walk into a group and they'll say, oh, don't do active surveillance, because they don't get it. It's a real problem. So they come with a caveat, but I can probably, whilst we're still talking or talking to the next man, keep an eye on the chat window, and if I find, I'll look and see. Where are you exactly?
I'm in St. Petersburg.
Oh, you're in St. Petersburg.
Yeah.
And the other thing is that maybe I can connect you. Our board president also is in St. Pete's.
Okay.
And he's the one who had surgery, and I'm pretty certain he had his surgery at Moffitt, but he hasn't gotten back to me. But I'll talk to him tomorrow. So he lives real close to the bridge.
Anything else, Stephen, for us?
I think that's great. So I'll call them tomorrow for the scheduler, and then I'll try to get the urine biomarker. Yeah.
At least ask a question.
Yeah.
And you can save this chat. I think it's in the 3 vertical dots.
Yeah, I saw that. I've been saving it. Yeah. Okay. Gotcha.
So you can save it, because obviously trying to write all this down is not easy.
Sure. So yeah, so I guess in general it's a good idea to probably get a biopsy at this point, right? There's no reason not to, or is there?
That's a question for the doctors, but yes, I'd say lean
Okay.
toward the biopsy unless you're a good candidate for a biomarker test, but even before biopsy.
Okay.
Stephen, I sent you that
Thanks,
Sarasota
Jeff.
group in the chat.
Okay, great.
Okay. All righty.
Okay,
Alan,
great.
in the Big Apple, what can we do for you? What's new and exciting?
I'm coming up on my 6 months. I have my PSA. I have to get it scheduled, but I'll do a PSA most probably 2 weeks from today. I know the don'ts, but how far out do you don't? Like how far out, if I'm getting tested on the 25th, how far out before the 25th should I stop exercising?
72?
Yeah, that sounds right. 72. And you know the drill, exercise, sexual, try to, stress is also a driver. Try not to,
You tell my boss
stress yourself out about it. And I think we learned, you don't by any chance take biotin, do you?
No, I don't.
As a separate supplement. I think we found out last week that was a no-no.
Yeah, we talked about that.
Yeah.
No, I'm not even right now taking a multivitamin, so no.
Yeah, we learned that last week too. Supplements seem to be a lost cause. That was the general consensus.
I had the accidental I had the accidental PSA in April, which wasn't scheduled, but was done when they were doing other blood work. So I have a kind of half marker. Easton dismissed it. He said it was too soon after the biopsy and didn't particularly care. It was 2.6, so it wasn't horrible. I'm just hoping I get a really good number on the 25th.
Yeah.
Well, I would definitely take a 2.6.
And then I meet with Easton again on the 2nd.
No unicycle riding, okay?
Yep. No, I'll stay up the unicycle, Eric. No circus work.
Okay.
Yeah, no riding the elephants, none of that stuff.
Yeah, there you go. You got it. You got to lay low for 72 hours.
Yeah, Netflix and veg or whatever they say.
I wish.
Anything else, Alan, or that's it?
No, that's it. I'm just dreading that I'm coming up on my 6 months.
Yeah.
Yeah, well.
Best of luck to you.
As we told Stephen, we all go through it, but it's a necessary evil to, just stay abreast and use all the tools in the tool chest for sure. Derek, did you want to share something this evening?
Yeah, I just wanted to talk about my 87-year-old father-in-law who recently diagnosed with esophageal cancer. They found a mass in the throat and did a biopsy on it, and it came back positive. I don't know what stage at what, but then they put a stent in the throat because he was having a hard time swallowing, and the stent has improved his swallowing tremendously, so he's now at least back to eating properly. At which point they ordered a PET scan, and the PET scan came back with lesions on the prostate, a lesion in the, I believe they call it ileopathic region of the pelvis, which is his lower back region, where he is exhibiting pain. And they did a PSA test on him, and he's 80.4 on his PSA, 80.4. Yeah. So at this point, I'm fearing the worst, obviously. And they are mentioning that it looks like metastasis has set in potentially. The next thing they are talking about or wanting to do is a biopsy of the prostate itself. And I'm going, well, do we even go down that path at this point at age 87? What are we going to do at this point? So other than make him comfortable. That's
so, Derek, where is he in your area?
He's in my area. Unfortunately, he's with Kaiser.
Okay, so make an appointment with Matt Rettig off the bat. Okay, and I think that he'll handle it. He'll handle it compassionately and the right way. He's at UCLA. He's really good. He knows.
Whoop, we lost Rick.
Whoop, what happened to Rick?
Rick, we lost you.
Oh, darn.
Hope maybe his computer crashed. But did you understand?
What I was going to mention, though, unfortunately, he is with Kaiser.
Well, you might have to
And
jump
so
ship
I
if
don't.
it's necessary.
Right. I don't believe. Go ahead, Eric.
Say might have to jump ship if he feels like it's necessary.
Yeah, if he's at Kaiser, you don't have. Sorry, my computer keeps doing this because it doesn't like the default microphones and speakers that I use. If he's at Kaiser, it's going to be really difficult.
Yes. Right.
And I don't
And
know
I
what to say to you because I
understood.
don't know. You won't get to a medical oncologist. And
That's the point. They are. He is seeing an oncologist this Friday to discuss immunotherapy in regards to the mass in the throat. So
yeah,
they're talking
yeah,
about
but
potential.
one thing's got nothing to do with the other, and the problem is that
Correct.
that guy, if he knows how to treat the mass in the throat, he's not going to know how to treat the prostate.
Understood.
And that's one of the problems. So he's got to get separate. And it's very, very hard to do that at Kaiser.
Right.
I think,
And that's why
I may have a name for a genitourinary medical oncologist at Kaiser. Let me
Gotcha. So yeah, his urologist at Kaiser right now. The next step with them is they're talking about the biopsy at this point.
Yeah, well, they
Derek,
shouldn't be.
That sounds to me like how is his health in general before this esophageal cancer?
Pretty darn good for age 86 or 87.
Okay.
Yeah.
Well, that was the point I was trying to bring up because if he was, I'm glad to hear that he was in pretty good shape for 87. I'm just talking personally. It would be about a quality of life thing for me to talk
Correct.
to the doctors about. That's what I cannot see. Of course, I'm not a doctor and way far from it. To go through a biopsy at this point, they're going to tell him what? He's got prostate cancer. They know that already from the PET scan. Right. I don't understand their rationale, but that's a good question. I mean, that would be the first thing. Someone like yourself that's knowledgeable can say, okay, why are we doing this? What's the end game? We're going to do a biopsy, and what are we going to do if we find whatever? Correct. And have them answer that question. In the meantime, that could be pretty stressful, and full of anxiety for an 87-year-old male that's also just been diagnosed with something but evidently they're handling that fairly well. It sounds like it, which I was happy to hear. But I mean, and that's just a personal opinion, but I'd want to know what are we going to learn? What are we going to do? And in the big circle of things, what about the quality of life? Does he really need to go through that procedure? Are we going to learn something that can reverse anything? I don't think so. No. Are we going to learn something that we absolutely can say, oh, go home, take these pills for 2 weeks and you're going to feel better? No, I don't think so. So, that I'm just sorry to hear about the whole deal, but I can understand and I've never heard anything good about this Kaiser medical shit. I don't know where they're located, but it doesn't sound like it's a good medical group.
Well, it doesn't even sound like they were doing PSA tests, him being over age 70. And all of a sudden, because of the other diagnoses, and they decided to do a PSA, or I should say the PET scan. Then they decided to do a PSA.
Yeah. So this is really the problem. We advocate for PSA testing, whatever age, and then you have a shared discussion with your doctor. And when you don't do that, this is the situation we finish up in. It's happening more and more, and all we can do is keep screaming at people that this isn't right. This isn't right, and things need to change, and that's what we try to do. And then you get the idiots on the right on Howard Walensky's The Active Surveiller who tell you it doesn't mean anything anyway. Those are the people I wish. I shouldn't say this, but those are the people I wish got diagnosed like this, and then they'd realize why the PSA test is important. But they don't get it. Right. I mean, it really gets my goat. But that said,
Go ahead.
That said, we won't go down the Howard line right now.
Okay.
I there's a couple of things that occurred to me. I don't know if I've got a name. Somebody mentioned, I don't know who it was. Somebody mentioned that they found a good doc who understood GU at Kaiser, but whoever it was, I didn't save their name. I'm sorry. I think there's a couple of things you can do. First of all, you've got to make it really clear that the oncologist that you're talking to is not who you want to speak to about your prostate. The second thing is, somebody needs to go with your father-in-law to Kaiser and sit with his urologist and you and and ask all these questions, because for an 87-year-old to advocate for themselves doesn't often happen.
Understood.
Unless he's really feisty.
No, very timid.
Okay, so you've got to go and you've got to say, look, why are we doing this? And if he has, I was sort of half listening before. You said was it a PSMA scan that they did, or just a regular CT scan?
I believe just a regular MRI. Yeah.
Right. So what you tell them is,
they did a PET and then they followed up with the MRI. Correct.
Yeah, but what sort of PET was it? Was it a
Full
PSMA
body.
PET?
The PET?
Because that's very important. You see,
Well, no,
if it was, go on.
I don't know. Also, I know it was a full body PET scan.
Okay, so you need to find out if that was a PSMA PET.
Okay.
And what did you say his PSA was?
80.4.
80. Okay.
Yeah.
Well, just call me tomorrow, because I don't want to talk about this stuff in this group. It's not fair for the group.
Understood.
And call me tomorrow and we can talk about some strategies on how to try and get it. But I think it's going to come down to you talking to the urologist and telling him, no, we're not going to do it, because we can do a PSMA PET, and that will tell us if it's metastasized, if whatever they're seeing is metastasized. The other thing is, you need to check before you call me whether the PET they did was a PSMA PET or not.
Got it. Thank you very much for listening.
Derek, is that too much on you with your journey and now having to deal with your father's journey? Can you delegate it to, or have somebody else come with you?
Yeah, a little more worry on my wife and her brother and sister. I can absolutely interject. I have the time and energy at this point. Thank you for asking.
Yeah, I'm worried about you too.
Concern. Yes, thank you for the concern.
So even if a third person comes and helps out, that would be great.
Definitely.
Yeah, Derek, I think you certainly have enough knowledge through your own journey, and that's more than one for anybody listening. It's not just Derek's been through a couple of medical issues. To be a wonderful advocate for your father-in-law and to find out what's been done, what are they thinking about doing, why are they doing it, and what's going to be the end result.
Yep.
And then getting your wife and the other family members together and making the best decision. That'd be great.
Excellent advice. Thank you, guys.
Okay, you're more than welcome. All right. Well, I don't have anybody else that wanted to any time. So does anybody else have anything to share or want to talk about anything pertaining to active surveillance? Oh, Ignacio wants to say something.
Yeah, if we have time, I have a question, kind of as a follow-up to Alan's. I'm having an MRI on the 23rd, and I have decided to stop consuming alcohol till then, and also, take it easy with exercise. Is there anything else that I should be doing, or in preparation for an MRI?
I know on mine they had me do a fleet enema beforehand. I don't know if that's prescribed for you as well.
I'll check my instructions. I don't remember seeing that, but I mean in terms of like behavioral changes, prior to the MRI. I mean,
I've never heard of any.
No.
I've never heard any kind of do's or don'ts before an MRI. I mean, I don't think you'd want to go out and work 16 hours and go in for an MRI.
I would not do that even without an MRI. So.
Yeah, but I don't think, and my guy, we do an MRI the night before and 2 hours before the procedure, and that's basically to get supposedly a clearer picture.
Yeah.
And of course, I'm sure there's people on the screen that had plenty of MRIs and never did it. I don't think you ever heard of doing an enema before his MRI. So I guess some do, and some don't. It makes sense
What
to
I have
me.
been told is to eat a light meal, or eat light meals the day before. Do not eat for 3 hours prior. And all that's fine, but I'm asking about any additional.
No, I think it all has to do with the digestive system. That getting things the picture.
Sounds great.
I don't think behavioral has much to do with it. I've never heard of it. And now I remember the instructions about the meals. That's standard protocol, I believe, before an MRI.
Right.
And do you know that this institution offers the T3, Ignacio?
Yeah, I'm going to UCSF, which is
Excellent.
like the best, at least close to me anyway.
Yeah, get some clean bowels and call it a day.
Sounds good. So alcohol is okay then, just in moderate.
I would. Yeah, I never saw that on the protocol. So.
Yeah, it was just
I don't think you want to go in there wobbly.
Abundance of caution.
I mean, I guess anything that causes inflammation, you could argue, just try not to do it ahead of time.
Yeah.
Don't make it angry.
Stephen, what do you got?
All right. Thank you, gentlemen.
You bet.
Stephen, you got your hand up? You want to?
Yes, I do. First off, if I didn't say thank you very much for the advice, I really do appreciate it. That's one thing I wanted to say first. And is there any diet and exercise studies about what you should do to? I don't know. I'm just.
There's lots of information.
Well, have you got about 6 months to read and go listen to lectures?
I just sent Erica.
And after the 6 months, you're not going to know anything you didn't know before. Basically, the biggest thing that's going to kill the males in this country is heart disease. So a heart-healthy Mediterranean diet is basically the best that you can do. There's some on the screen that definitely go vegetarian, stay away from red meat and dairy. Sugar seems to be an issue. You could read till the cows jump over the moon, literally, to find out about diet. But we know that a Mediterranean diet is a heart-healthy diet, and that goes hand in hand with trying to stay healthy and avoid the various cancers that are out there. The one thing that has been, there's plenty of data and studies, exercise. Exercise is good. Exercise is good for any kind of cancer. And of course, any PCP, is going to tell you, you should exercise every week to some extent, depending upon how, your own particular situation. So the diet, that's way up there for debate. It's certainly up to yourself. If you feel you need to change your diet, if you're not eating enough vegetables, or you think you got too much red meat, or omega-3s and omega-6s. Now the word on the street is that a blend of those omegas are good. Before, one of them was out, it was no good. Now it's back in the limelight as being together in moderation. They seem to complement each other and make things work. Everybody has a different opinion. Dan in Idaho that you see down there, he cut out a whole bunch of, I think he cut out corn. And go ahead, Dan, tell them what you cut out and what you like.
Well, primarily I cut out the omega-6, some omega cereals that have omega-6 in them that basically have corn in them. And I gave up dairy for the most part. I found a substitute for milk that I use. And I take extra fish oil, salmon oil for the omega-3 in the morning.
I posted a bunch of good links in the chat window too. So
Okay, great.
And that seems,
paste all
that seems to have worked for Dan real well. And I still have a problem with almond milk, soy milk, and all the rest of the milks that aren't milk at all that they market as milk. That still aggravates the hell out of me. But who am I to complain?
I use flax milk because it has more omega-3 in it than walnut milk.
Do you use flaxseed oil milk?
I don't have that as part of my routine.
But I'll tell you, Gary, you'd have more trouble if you took that flax milk with a salmon oil tablet at the same time.
Ooh, you'll turn into a salmon.
That's not happening in my lifetime. That's for damn sure.
You need milk and magnesia. I was going to say,
you're going to start developing gills soon, you know.
Eric had mentioned fleet enemas. I know I had to do fleet enemas prior to my transrectal biopsies of the prostate.
Yeah.
Did they recommend that for transperineal? Does anybody know? Fleet enema prior to transperineal.
I mean, unless they need to clear the bowels for spacing, I don't think so.
Okay.
Because nothing's going through the rectum, but I don't know. Rick, do you know anything, or Gary?
I know they certainly asked me. I certainly had to do it for the transrectal, but I have no idea about the transperineal.
Something's given
transperineals.
My instinct is no. There's no need for it, but I'm not a doctor. But it's a good question to ask for my next transperineal.
They had me do it, and it actually it's caused irritable bowel with me. But yes, I had to have a enemas for the transperineal.
But do you have IBS?
I do have.
Okay, well maybe the fact that you had
it kicked it up again.
is why they requested it.
What kicked it up?
The enemas, they think, kicked up my IBS.
Got it.
And you, Gary, they didn't have you do it for your transperineal?
I don't recall. I don't think so. For the MRI, two for the MRI night before and a couple hours before, but not for the transperineal. I don't remember. Okay. I don't think so. Again, I think that's another one of the doctor's preference. I don't think, as I said, I don't think you ever heard of getting an enema before his MRIs. Somebody out there, and I think it was you, that was like, oh, I never did that, and that was a prerequisite. Both times, 3 times that I've done it. Just like one doctor's doing a DRE, and the other doctors they're not touching it, literally. Yeah. So it's a done deal in a lot of the framework. All right, gentlemen. Anybody else have anything this evening? Eric has something. I do. Hands up.
I was when I was researching my MRI fusion biopsy that I'm going to have in a couple of months. The current doctor at Emory can only do a cognitive fusion biopsy, which means he doesn't have the software to overlay the MRI to the ultrasound in real time. He would have to go back and forth with 2 screens and cognitively try to aim for the lesion. So I don't know, how important is that to have the appropriate equipment to do a full overlay?
I would say I'd pass and tell him you want it done with proper fusion with the software.
Yes.
That's what I was
What
thinking.
is what is the other term? Cognitive, and then what is the what type of fusion is what you want?
I guess the cognitive part is dropped and it's just called fusion.
I think
Fusion
so. I
MRI.
don't know, but I know exactly what you're talking about. And you don't want you don't want a cognitive biopsy.
Okay.
Targeted fusion MRI, I would guess you would call it.
Yeah, they're both targeted. It's just one uses
cognitive versus software.
Yeah.
Actual mapping.
Right. It's like Donkey Kong or something, some sort of game he plays while he's doing it or something.
Moderators,
Go
ahead, Rick.
I can't believe that they don't have that equipment at Emory. That
was a shocker for me.
Oh.
Maybe he doesn't have it in his office, but maybe there's another office somewhere that has it.
Yeah, I'm going to press harder on that.
Well, be sure to let us know what you come up with. That's for sure.
Absolutely. Thank you.
Derek, you were saying?
Yeah, I just wanted to make a suggestion to the moderators that possibly before you shut a meeting down, you could say, we'll give you a minute or two to download the chat, because sometimes I've missed downloading the chat because the meeting was shut down too quickly.
Excellent point. Thank you very much.
No problem.
Thank
I
you.
love it. I love that suggestion.
Thank you.
Is anybody
like to download the chat right now?
Is anybody in the group a veteran?
There you go, Dan.
Did you guys submit a claim through the VA for prostate cancer?
Yeah, I did.
Yes, sir.
And I got my own.
Okay, so Donald, we have. Are you new to the group?
Yes, I am. Yeah, my second week.
Okay, and do we have your email address?
I think so. I put it in.
Okay, so I will make sure that you get a reminder. We have a veterans group, and that group specifically helps you to put claims in for whatever your condition is. The majority of the guys in that group are prostate cancer, but not all of them. Why don't you just tell me, do you mind telling me your last name, or if you do, put it in the chat window and send it to me so I can find you?
Yeah, I can give you. I don't mind giving. My last name is Jones. My email is. You ready?
Yep.
DN, the word and, BM like boy Mary, Jones, the @ AOL.com.
Okay. So why don't Dan? Sorry, Don. I didn't mean to say Don. I meant to say Dan. Dan Gifford.
Donald.
Dan Gifford. Why don't you just take 2 minutes and give Donald a quick heads up on what happens under the command of Captain Jim. Yeah.
So there's the first and third Tuesdays, there's a vet meeting where they talk specifically about vet healthcare. And Jim, he's a Vietnam vet, also a retired civil servant. He's very, very knowledgeable about the VA process, very, very helpful in getting claims. He knows exactly what to do, exactly what to say. But in the meetings on the first and third Tuesday, and then on the fourth Tuesday, there's also a meeting, Vets Speaking Freely, where you can talk pretty much about everything. The one on first and third Tuesdays, like Rick said, primarily prostate cancer. But we talk through all of these issues. What about this? What about this? So it's a great addendum to what we're talking about here. But whole VA challenge. So if you want to just send me a note, I can give you more, or just meet with us next Tuesday. You go to the groups on the ANCAN website and you can find the site.
Okay, at what time on Tuesdays?
That's 7 o'clock, 8 o'clock Eastern.
Okay, thanks a million.
No worries.
I'll put the link for the group in the chat window for you right now. I'm just getting it so you can see that, and we'll sign up so that you get a reminder.
Oh, thanks a million. Thank you.
Thank you, Rick.
Okay, while Rick's doing that, Google will help us decide. There are two types of biopsies, the cognitive fusion and software assisted fusion. Cognitive fusion relies on the urologist visual interpretation of the combined images, while software assisted fusion uses algorithms, our favorite thing, to register and overlay the images. So now we know that we have to ask for software assisted fusion biopsies. MRIs, excuse me. How about that?
Thank you, Gary.
I wanted to know, well, Google knows everything, as usual. I know nothing. Google knows it all.
All right, now's a good time to save the chat.
I wanted to mention two things. One, Henry had joined late, and then I just saw he dropped off, so I didn't know if he had anything to say or not. Secondly, Eric, I had forwarded you the document from Captain Jim Marshall titled How Not to Fail a PSA Test.
Yeah.
I don't know if you want to send that out in a group mailing, or if you want to ask Jim first if it's okay to send that out in a group mailing to the AS group specifically.
Yeah, I actually have it already and already asked him that same question. He's like, go for it. Share it.
Okay. I think that would be very beneficial.
We should post it in one of the meeting notices.
Well, yeah, it would have to be because it's a PDF and I can't share a PDF in the
It's an
chat.
awfully long document as well.
Yeah.
I guess you'll
send
have
it to Kiernan. Is that right, Rick?
Yeah, Kiernan. Kiernan at ancan.org. What's the matter with me? I can't talk.
Okay.
And Dan, you got something to add?
Yeah, this is for Eric. I'll replay my story briefly. That when I had a year and a half ago, I had two areas of my on the MRI that were pyrad 4. So I had a cognitive fusion biopsy. That's because that's what my doctor was able to do. I believe he's a good doctor. I really like him, and he has his own office, and that's for that reason. That's all that was available. And at that time, he took out 20 cores. He didn't find anything, so I'm relying quite a bit at this point on a low PS. My PSA is quite low, and so I'm relying on that. But still, I'm still looking to have a MRI guided biopsy, and when I suggested that to my doctor, he was okay with that. So I'm probably will have another one maybe this summer or so from a doctor who's in Boise that does the MRI guided biopsy.
Gotcha. Thank you. Rick?
Gary, would you mind reaching out to Howard and just ask him if he has a recommendation for an active surveillance doc at Moffitt for Stephen?
Will do.
Thanks. And then we'll let you know, Stephen, and I'll do my checking, and we'll get you sorted.
Sure, appreciate it.
Okay.
Anything else before we turn off the recording?
Yep. If you got something in the chat, copy it, because we're getting ready to scat.
All right, I'm going to turn off the recording now.
Okay.